Right, good afternoon everybody, and thank you for coming back in out of the beautiful scenery outside. So my name's Nick James, and I'll be co-chairing this session with Omolara Fatiregun, who's sat to my right. And we're talking about the Lancet Commission on prostate cancer. Now, we're all here in Lugano because we want to improve the outcomes for men with prostate cancer, and we've spent a lot of time talking about the latest high-tech treatments, stereotactic radiotherapy, PARP inhibitors, and so on. But I think one of the things that's been very striking to me from this Lancet Commission, and I'll be the first speaker, is that really to impact prostate cancer globally, the issues are not around when do we give a PARP inhibitor. The issues are around how do we diagnose men promptly and get them on the right treatments as quickly as possible. And this is something we don't do that well at already, and we're going to see a big change in the demography of prostate cancer in the coming years. And that's something that I want to highlight. And we've got a fantastic panel of global oncology and urology oncology experts who are going to talk us through some of the issues. So these are my disclosures, to be honest, not really very relevant to the talk. So the Lancet, as I'm sure you're all aware, is a medical journal, and they've been running these commissions on topics like women's health, global surgery, global radiotherapy for quite some while. And this was the first commission that they've commissioned on a specific disease, and they chose prostate cancer. So this has been a substantial process going back 3 or 4 years. So the first meeting was in September 2020, but upstream there was a whole load of work done on finding suitable experts who had the right perspective. So people had to be experts in their fields, oncology, urology, whatever, but also we wanted a geographically diverse spread, and we had health economics experts, public health, epidemiology, patient representatives, the whole spread. And it took a long time to assemble the right panel, and we've then had a series of meetings. The final paper has 40 authors on, and a number of the authors are either in the audience or on the stage with me. And as you can see, they are indeed very diverse in every respect. In order to look at the problem, we split it up into 4 subgroups. The first was just looking at what the evidence is, what do we know already, chaired by Ian Tannock. The second was looking at the issues around diagnosis, chaired by James Nadeau, who's on the stage and who will be taking part in the panel discussion. And then we had 2 disease management groups, one led by Felix Feng, who we were hoping would be here today, but unfortunately, as Silke said yesterday, is unable to be here. And the second was looking at optimizing treatment for advanced disease. So the first thing, just looking at the current evidence, was the striking, the already high prevalence. So prostate cancer is the commonest male cancer in 112 of 185 countries in the world, which is something I didn't know myself. And it's 15% of all male cancers globally. And that's the first thing. The second thing is you can see the distribution of current cases. This is what is going to happen in the next 15 years. The change is staggering. And what you can see is that the red bars, which are the new cases that will be seen, are huge. And they're in areas that are not necessarily seeing a lot of cases at the moment. So if I draw your attention to Western Africa, about halfway up, it's common already in Western Africa. It's going to get much, much commoner. And so this rate of change is going to exceed the sort of traditional disease management models of expanding numbers of urologists, oncologists, and so on. So although that is going to be important, it won't be able to keep pace with the rate of change in cases. So we're looking at more than doubling by 2040, and this is almost certainly an underestimate. If we look at deaths, we see the same pattern. So this is the current pattern of deaths, and what we're going to see is everybody will see increases. So Western Europe, North America, although we have relatively elderly populations, improving life expectancy is going to still drive up both the number of cases and the number of deaths. But you can see that the number of deaths is going to go up everywhere, and it's going to double in a lot of places, and particularly in low and middle income countries. So moving on, and these are just the headline things, the diagnostic pathway is key because metastatic disease, as I don't need to tell this audience, is incurable. So if we want to improve the death rate or reduce the death rate, we need to diagnose the disease earlier. Against that, not against diagnosing it earlier, but one of the problems is that in high-income countries there is an issue of overdiagnosis. But in low and middle income settings, it's the opposite. It's underdiagnosis that is the problem. And with rapidly rising cases, this is going to be an increasing problem. In order to address this, we make some quite detailed suggested approaches, but just because of just straightforward issues around how long it takes to train a urologist, say, we're going to need to base diagnostic systems around new case mixes, new skill mixes, using nurse-based biopsy, for example, which in fact is what we already do at the Marsden where I work. So I'm not proposing a second-class solution here. We will also need to use tools that are rapidly becoming available, such as artificial intelligence, to augment and supplement the sparse availability of pathologists, for example. In parallel, because the rise in prostate cancer cases will be driven by improving life expectancy, we will see increases in things like heart disease, diabetes, and so on. So any strategy aimed at dealing with prostate cancer will in parallel have to deal with a whole lot of other things as well. And one of the things we identify as key, and I'll come back to this, is using things like smartphones as tools for change. The second thing is ethnicity, and again, it'll be well known to this audience that prostate cancer is more common in black men than white men, particularly probably West African origin men. So ethnic mix, ethnic origin is globally a key driver of high death rates, and incidence rates are driven by a mix of how much PSA tests you do, how much early diagnosis, and so on, and by your stage at diagnosis. But ethnicity per se is something that is very much under-researched. And again, we make specific recommendations around how this needs to change in the future to improve outcomes for men globally. Moving on to treatment. So we've spent the last day and a half talking about treatment, mostly for advanced disease. And it's clear that there are amazing treatments available and getting more amazing by the year. But we also know, and this has come up in a number of talks, that one of the striking things is that even in countries where expensive treatments are funded, they're not uniformly delivered. So under half of men in the United States and in the United Kingdom receive what you might want to call combination or intensified androgen deprivation therapy up front. So simply delivering what we know works is a really easy way of improving outcomes, and we don't do it. In parallel, we have to plan for success. So if we plan to improve diagnostic pathways in low and middle income countries, that we for sure will drive a need for more surgeons, more oncologists, more radiotherapy kit, and so on. And we need to plan for these two things in parallel. So we make 4 headline specific recommendations. So the first is that if we're going to improve outcomes, we need to improve diagnostic pathways, and we make different recommendations for high and low income countries. The second is, and I think this is key, you need to empower men by giving them access to their own medical records. Now, smartphone penetration is very high in low and middle income countries, so this is an obvious tool to improve that, but it's a tool as well in high income countries. Thirdly, we need to make pragmatic practice recommendations affordable within the relevant settings for treatment, and by harnessing that to patient-held records, you've got a route for improving use of things that we know work. And then finally, there's a need for more research always, but particularly there's a need for more research appropriate to the needs of low and middle income countries. So for example, we do not know whether we should do PSA-based testing. So we make specific recommendations about ethnicity because we don't know for example, whether the treatments apply equally in all groups. So these are the headline recommendations: improve diagnosis, integrating in with men's health more broadly, empower patients for informed care, implement resource-sensitive guidelines, and improve research and evidence-based practice. Thank you. So who's? Sorry, a minute. So next speaker is Omolara, who is talking specifically about radiotherapy needs and the Nigerian experience. So, okay. Omolara.
Thank you, and good evening, everyone. I don't have any disclosures. I'd like to start by appreciating the organizers for this opportunity. It is worrisome that the current statistics project a surge in the incidence of the most common cancer in men of African descent. And we know that this increase is unpreventable by just lifestyle and public health interventions alone. And the fact that the increasing mortality will be seen in sub-Saharan Africa, we know that the men from this region present at younger ages with late-stage disease. And these regions are plagued with, under-treatment, insufficient staging, as well as out-of-pocket payment. And, of course, we are aware that there are different financial profiles of people in LMICs. We have the rich that are able to seek expensive care, as well as the poor that lack the financial power. And the last group constitutes a greater proportion of the population. So, in order to maximize radiotherapy for prostate cancer, the big question is that, are we planning for a surge, in late-stage disease? And if the answer is yes, right, all hands must be on deck. We must prepare to offer palliative care, right, to late-stage presentations, pain control, oncologic emergencies, as well as localized radical treatment for these men who present early. There exist several surmountable challenges in Africa, and you see that before we can maximize the use of radiotherapy, it must be available, right? Some African countries don't even have radiotherapy machines. It must be accessible for those who really need the treatment. And apart from that, it must definitely be affordable, because we know a lot of patients pay out of pocket. Now, taking a deep dive into those challenges: availability of cancer treatment services, the machines, cancer medications, capacity building around, the radiotherapy centers, accessibility of the services, affordable costs, like I mentioned before. But I think one of the major things that layers beneath all this is the political will, right? If the country has a political will, then it will provide leadership in cancer control. There will be policy development, right? There will be budgetary allocation to curb the rising cases of cancer. And so to speak to this, I just wanted to, in terms of overcoming those challenges, I would be discussing steps taken so far in Nigeria, a West African country with over 200 million population, 6 geopolitical zones, and 36 states. So what was one of the major milestones, with cancer control in Nigeria was the establishment of the National Cancer Control Program in 2006, which was executed by the Ministry of Health. And it focused on 5 key areas: public health, education, cancer prevention, early diagnosis, effective treatment, palliative care, with 5 yearly updates and involvement of private international organizations with interest in cancer control, the American Cancer Society, the National Cancer Institute, just to mention a few. Now, this step, right, in establishing, this was 2006, has led to the establishment of now the National Institute for Cancer Research and Training and Treatment. That's NINCRAT. That was in 2017. And it's supposed to provide leadership. It was established to provide national leadership on cancer research and treatment, as well as control in Nigeria. So why is this a major step? Because now cancer control in Nigeria is handled by an agency set aside with its own budgetary allocation to focus on cancer, right? It's pulled out of the Ministry of Health with other competing health needs. And you see they've developed the National Cancer Control Plan for 2023 and up to in 2027, which has already been launched by the Minister of Health. In terms of availability, so from 2006 upwards, the first radiotherapy machine was installed in 1969. And this paper by Nwako et al., which was published in 2010, showed that we had, at the end of 2010, we had only 5 radiotherapy machines and 2D brachytherapy machines in Nigeria. Fast forward to 2024, all those machines have been decommissioned. And currently, we have 25 new radiotherapy machines, and we're still counting. We have the first PET scan machine in West Africa, established by a private organization. We have a lot of public-private partnerships as part of things that were lined up in the National Cancer Control Plan. And you see the former president, commissioning the first PPP center in Lagos. Now, we have other centers in the pipeline, up to 14 of them. When I say pipeline, I'm not saying on paper. They already have the structure and, it's going on. And very soon, there are private, public PPPs where we have private investors involved in it. That's in terms of availability. Now, other milestones in terms of access to cancer chemotherapy. We have the NCAP program, which is in collaboration with the Clinton Access Initiative, currently being implemented. Also upgrade of oncology centers across the country. But I think one of the major ones is the implementation of the Cancer Health Fund in 6 federal institutions in each geopolitical zone. I put the color code in the map there. So we're still at the first phase that is focusing on treating indigent cancer patients, that have breast, cervix, and prostate cancer. We also have private and state insurance programs, right, now covering cancer treatment. And you know that this year, in 2024, the budgetary allocation for cancer treatment is about 200 million naira. And in total, over the past 4 years, Nigeria has invested 1.3 billion naira. That's about $4 million USD, in projects related to cancer treatment. So the next slide. So because we've had political will and national leadership, it has led to sensitization of other policymakers. State governments are developing their own cancer control programs, right? And even other organizations have also been established, and non-governmentals. But we know that there's need for continuous advocacy. Nigeria needs 200 machines, right? And we need to scale up these programs. We need more public-private partnerships. International collaborations, especially in the space of clinical trials, because we know that men of African descent are underrepresented in most clinical trials globally, and yet we give them the same treatment. And also, we must also ensure that there's sustainability of these programs, maintenance, evaluation of processes. So in conclusion, I'd like to say that to prepare for this surge and maximize the use of radiotherapy in Africa, African countries, especially LMICs, must identify their unique challenges and take deliberate, actionable steps towards achieving these goals. Thank you.
Very impressive Swiss timing. Thank you very much. So moving on, Dr. Ekeke is going to talk a little bit about the diagnostic pathway for dealing with rising cases in Africa specifically.
Thank you for inviting me. I have no disclosures. I am from Port Harcourt, the oil city in Nigeria, West Africa. Prostate cancer is the leading cancer in terms of incidence and mortality in Africa among men. The incidence is still rising due to improving diagnostic capabilities and also the actual rise in increase. There's poverty and, as a result, poorly funded health infrastructure. The hallmark is late presentation and delayed diagnosis, leading to poor outcomes. There is therefore the need to adopt strategies to improve diagnosis for better outcome. So this will involve shortening the diagnostic interval, doing risk assessment, getting patient and physician in shared decision-making for early diagnosis, detection, and then when you diagnose, you do the staging. There is lack of knowledge of prostate cancer among our men, and there is lack of accessible, affordable, and culturally responsible primary healthcare services, with the resultant patients presenting with advanced and terminal diseases. We see patients coming with fracture of the long bones and paraplegia as first presentation. So patient education is crucial. If we raise awareness about prostate cancer risk, It will lead to earlier presentation and diagnosis. We need to adopt community-based campaigns to help disseminate the information. So patient screening and early detection. I know that screening is controversial, but research shows that screening is very beneficial to Blacks and Africans. Early detection is important, and we advocate shared decision making. Screening of target group will improve the specificity and avoid over-detection. Now, what we're looking at is developing risk stratification model specific to Africans. And by the way, I'm talking more for sub-Saharan Africa except South Africa, because the North African countries, North African and the others, they have slightly different. So what I'm talking about, sub-Saharan Africa. So the patient's age is important, the race, the family, PSA. Here we're not talking about just PSA level, all the PSA derivatives. And then yesterday we were told that DRE may not be so important, but it is very important in Africa. And we don't have problem convincing people for, I don't have that experience. We just explain and they adopt it. So we look at all the PSA derivatives, using them to make a diagnosis. Now, another thing is that prostate cancer tends to be earlier among Africans, and they also progress more. So we advocate starting screening at the age of 40 years. And we don't have any study right now to say when to stop, so we adopt the universal 70, 75 years of stopping. And of course, apart from those with family histories and those carrying mutations, we also consider age-specific threshold in PSA. We advocate 1 year interval in testing. The second strategy is to increase access to biopsy services, because lack of biopsy services hinders accurate diagnosis. We need to promote training of healthcare workers to perform biopsies and interpret the results. And we advocate image-guided biopsies. However, we have a few places now where we can have MPRI. So where available, we advocate that they use them. But the common thing in Africa is use of ultrasound-guided biopsies. And we prefer transperineal approach so that it can reduce infection. But this may sound shocking or primitive, but over 30% of diagnosis is done by finger or digitally guided biopsies. And the yield result, because most of them present late, so it's easier to get that. Immunohistochemistry services are available, but they are limited. Now, there may be need for biopsies, and we have specific indications. We can also utilize biomarkers when available, as well as genetic testing where available. I will come back to that. So imaging is important. It helps us in decision-making for biopsies and staging, and it will also guide biopsies. Where available, we prefer pre-biopsy MRI. Then it will help in staging and detection of metastasis. Currently, we have conventional imaging in most centers. For MRIs, we have some 1.5 Tesla, and bone scan machine, a country as big as Nigeria, we have only 2 isotope bone scan machines. But new generation imaging, as my colleague just said, about a year ago or thereabout, we have a new PET CT scan. So where available, we advocate that it should be used. But what we want to say is collaboration for limited resources. So the best way to help us is regionalization. For instance, immunohistochemistry services, we have 4 centers that they pool the resources, so we can send the sample to that place. We also advocate telepathology so that we can share the slides with other centers, and genetic testing Our cancer registry is problematic, so if we can regionalize it, which we have done, it can help. We need a multidisciplinary approach. The urologists, radiologists, pathologists, and oncologists developing guidelines specific for Africa to help improve the diagnostic pathway. In conclusion, we need a comprehensive approach involving creating awareness, infrastructure development, training of workforce, research and collaboration, and all this will lead to policy changes that will strengthen the capacity for early prostate cancer diagnosis to address this rising challenge. Thank you very much.
So very impressively to time as well. And I think one of the things, just on the research thing, so we were talking today about potentially recruiting to Stampede 2 in Nigeria, which I think if we can pull that off, that would be fantastic. So next up, Vedang Murthy from Tata Memorial in India is going to give us kind of the same talk, but from the Indian perspective.
Thank you, Silky and Aurelius, for asking this rather intriguing question. What can we learn from the Indian healthcare system? Actually, the answer lies on the last slide, but I won't go there because then it will not give me a chance to beat the cowbell. I'll start talking about cows. This kind of in-your-face inequality is very common in LMICs, including India. But every healthcare system, every country has more subtle manifestations of inequality. The question is, what are we going to do about it? We have a 4-tiered network of public and private hospitals, but let me give you 2 facts. Only a quarter of our population has health cover. And a whopping 60% of the total health expenditure is out of pocket, which is way above the global mark or way above what is desirable. This brings me to another very important fact to put in context. Doctors and oncologists make major treatment decisions for patients. They are in fact even expected to take these decisions for the patients. And although we have been talking about shared decision making in almost every talk, that is less common than you may think. If I give patient 3 options with 5 different sequencing of treatment, they're going to look at me all funny. What is this guy? He doesn't know what he's talking about. So while the patients are thinking about their cancer control and logistics and travel to the hospital, we are worrying about what is essential for treatment, what is avoidable, and what is actually critical to drive the costs down. This brings me to the central theme of my talk, cost efficiency, which can be done in many ways. And I'll give you some examples related to prostate cancer as we go along. Indigenization has been a great part of our cost efficiency. A telecobalt machine at a fraction of a cost of a linear accelerator is excellent for palliation. We've also found local solutions for radiotherapy accessories, including 3D printing technology, which is just not reverse engineering. We have adapted them to Indian patients' anatomy, and this is a huge cost saving because this is a recurring cost for a lot of patients undergoing radiotherapy. Our surgeons have a new toy. It is a robot called the SSI Mantra, and it is going through its paces. It's already available in the Indian market. It may be available soon in the West as well. And a rough estimate of the installation and running cost as compared to the existing market standard is about a third. Huge cost saving, again, for the healthcare system and for the patients. Now, this is the interesting part. How do we indigenize systemic therapy? Well, in other words, it's called generics. It has received some negative media attention and sometimes justified because there are some bad apples in the basket, so to say. But this forms a backbone of driving the cost down, and we rely on this heavily. can we do something about choosing the right generic? So this is a multi-step framework for choosing these generics we have adopted in our hospital. It includes a checklist of checking the robustness of the company that is making it, a technical assessment of the drug, and a financial analysis. And only the top 2 or 3 make it to the hospital pharmacy. And using this approach, this is a small study that one of my colleagues did, very recently published. 10 patients using the innovator, about 100 using the generic abiraterone. We looked at some simple clinical endpoints like PSA another time and RPFS, and reassuringly, we're not getting it completely wrong by using these generics. So this is very reassuring for us. Coming to reduce, and what better than to reduce dose of abiraterone, and ably guided by this certain Indophile that we all know in this forum. This is a survey of Indian oncologists, and a large majority of whom have already changed or are happy to change to 250 milligrams after food of abiraterone, and this can have huge potential savings, not only in India, but everywhere in the world. India is a large country geographically, and patients find it difficult to travel to the hospital. So this is the Tata Memorial Center hub and spoke model. The main center in Mumbai provides infrastructural, administrative, and financial support to smaller centers around the country, which over time develop and become hubs themselves for other smaller centers. So if the patient can't go to the hospital goes to the patient. Now, moving to reduce and simplify. You know, we radiation oncologists love our bells and whistles. We have a lot of technology, we have a lot of gadgets. And when we do SBRT, with all this stuff, it looks like the patient is ready to be launched into space. A lot of our patients and our healthcare systems cannot afford this. So is there a way of doing things much more simply? Well, we have put in a lot of effort in standardizing simulation, planning, and delivery of treatment with good image guidance, all of which come for free. And we do SBRT in a much more simple way, and we get good results. Now, somebody may question that this causes more toxicity, but hold on. This is the interim analysis of the randomized trial that we're doing, looking at 5 fractions SBRT in high risk versus 5 weeks treatment. And the grade 3 toxicity is just 1% using this kind of SBRT. Again, very reassuring for us. Replace. What better to replace ADT with an orchidectomy for metastatic patients, and using all the money that is saved for life prolonging, well, RPs now, apparently 58% of us believe it should be called RP. And I did a quick survey of uro-oncologists. 60 to 80% offer orchidectomy for metastatic patients. And most interestingly, about 50% of the patients accept it. Again, a huge saving for patients. Finally, we often get only one chance to get things right, which is the first treatment. So we lean towards over-treatment. Now, again, somebody may raise an eyebrow. Is that all right? Let's see if the patients accept it. This is an informed consent form, a snapshot, which clearly says from the trial that if you have the 5-fraction treatment, the side effects may be more. And we ask them, if you're given a choice, which one will you accept? Of course, they don't have a choice, it's randomized, but a whopping 92% said they would still want SBRT because it is so convenient. Which brings me to the last slide. This is a very intriguing Hindi word called jugaad. Basically, in simple words, the rough translation is making the best of what you have from the resources that you have. And if you have to take away one thing, it would be using this kind of an approach, which is both frugal and flexible while being inclusive. Thank you.
Thank you. That was a fantastic talk, and I like the last word. Stacy, sorry, you'll need that. So So inequality, of course, also exists in high-income settings as well. And so Stacy, who's a urologist in New York, but is a sort of queen of social media and reaching disadvantaged populations. So.
Well, thank you so much, and what an honor to be on this absolutely incredible panel. I don't have any relevant disclosures. You've heard a wonderful introduction from Nick James earlier on the Lancet Commission, and of course, two of the recommendations for dealing with the surge in cases include artificial intelligence and social media. So a very nice section on that in this document, highlighting the great potential, but also the risks. So I'll briefly highlight that here. And one of the reasons this is so important is just because of the massive rise in use of the internet globally. These are some of the 2022 data from the World Bank showing in Latin America and sub-Saharan Africa the rising use of the internet. But even more widespread than that are mobile cellular subscriptions. You can see these extremely high numbers. It is basically ubiquitous worldwide. And so it is, even if we just reach people through voice or text messaging, these platforms can really be leveraged. So this was really the conclusion of a recent review of mobile health in low and middle income countries, where in fact, in some countries, mobile connections are actually more readily accessible than electricity and clean water. So these are really useful ways to do things like reminders for medications, behaviors. And also, things like AI algorithms and apps are very easy to scale once they've been developed with minimal costs compared to things like increasing the number of healthcare providers. Now, in high-income countries, these online networks can also be a great way to reach minoritized groups. For example, these are the latest U.S. statistics on social media platforms, and you can see there's the highest use among Hispanic and Black U.S. adults. So really, through the spectrum of prostate cancer care, there's many potential roles for social media and artificial intelligence, beginning with raising awareness, because low awareness is one of the main reasons for high mortality from prostate cancer. Also, a lot of utility in screening and diagnosis, and we've heard multiple times in this meeting about AI-assisted radiology and pathology. For treatment selection, one of the big emphasis in the Lancet Commission is on AI use for tailored advice based on cloud-based medical records. But these networks also allow for other opportunities, such as virtual tumor boards, which have already been used in India and in the US to help improve treatment management selection. Another great opportunity is the use of telemedicine, and this has even been done through networks like WhatsApp. And finally, for survivorship, social networks can be very important to get advice and support from the community. These are a few examples of our work in the U.S. using social media. For example, we did a prospective study showing that a podcast series was a useful way to provide public education about prostate cancer genetics. Also, in collaboration with the Prostate Cancer Foundation, we did a prospective study of a Facebook ad campaign to raise prostate cancer awareness. These methods are also being used globally. For example, this is a campaign that's discussed in the Lancet Commission. It's called Project Pink Blue in Nigeria, and this is a campaign to raise awareness for cancer. As I mentioned, these networks can also be used for telemedicine. So just as an example, this is a very interesting study in Mexico using WhatsApp to provide oncology care for older adults age 65 and above. And they were able to do geriatric assessments and chemotherapy prescriptions using WhatsApp. Here's another interesting study out of China, where one of the very popular social networks is WeChat. And this study showed that doing pelvic floor training through WeChat resulted in improved continence after prostatectomy. So very interesting to see use in survivorship. But there is a dark side, and this was exemplified during the Ebola outbreak in 2014 in Africa, where they found that tweets with misinformation about Ebola spread way more, even 3 times as far as medically accurate tweets. Unfortunately, this is also the case with prostate cancer. In fact, our group has looked at English language content on most of the popular social platforms and found that, unfortunately, misinformation is really widespread about prostate cancer. Unfortunately, it appears that the same is true in content in other languages. As part of an R01 project, we've been looking recently at prostate cancer content in Spanish from Latin America. And in preliminary data from 100 Spanish language posts, we're seeing 22% with misinformation, such as this example here, 3 plants that can cure your cancer that the pharmacies don't want you to know about. Now, AI actually may do a little bit of a better job. So this is a study that we published earlier this year, looking at the top 5 search queries about the top 5 cancers using 4 different AI chatbots. And actually, here, the information was pretty good quality, and we didn't see any misinformation, but there were other problems. It wasn't easily actionable for lay health consumers or easily understandable. And there may be some additional concerns. This is some unpublished preliminary data where we did the same queries using the free version of ChatGPT versus the paywalled version. And actually, the free version had significantly worse readability than the results from the paywalled version, raising concerns about health equity. Another concern is representation of diversity. In this study, we examined the top 150 websites in a Google search and the first 150 videos about prostate cancer on YouTube. And unfortunately, of all the over 1,500 people featured in this content, by a consensus panel of stakeholders, only 9% of the people were perceived as Black and 1% as Hispanic or Latinx. And this can actually have significant ramifications. So we did focus groups with Black patients with prostate cancer in the US who said that because they don't see any Black men on the websites, they thought they were less likely to get prostate cancer, which is actually the opposite. Same thing with videos online about prostate cancer clinical trials. Black adults are also underrepresented in this content, which is very concerning given the underrepresentation of Black patients in clinical trials. So in conclusion, there's certainly great promise from social media and artificial intelligence to help with the surge in cases by raising awareness, clinical care, and support. But there are really some significant concerns, including poor readability, misinformation, and limited representation of diversity. So in order to really harness the benefits, we need to ensure accuracy, comprehensibility, and equity in the provision of digital information and services. Thank you so much to the groups who have supported our work and our collaborators and for allowing me to participate in this session.
So I think you can see that what we've tried to do is not just identify problems, but identify really innovative solutions, and all of our speakers have done this. So next up is Fernando Maluf, who is going to give us a perspective from the Brazilian healthcare system. Fernando.
So thanks so much, Silke and Aurelius, for this invitation to be speaking at this outstanding meeting. So this is my disclosures, and these are the topics to be discussed. So regarding epidemiology in Latin America, we can see that there are epidemiological differences in the region. There is often inadequate data collection. There is under-notification of cancer diagnosis and mortality. And there are different healthcare systems in Latin America and also inside Brazil, with limited access to drugs, hospital, delay in surgery, and lack of radiation facilities. Because of that, the mortality rate in developing countries compared to developed countries is at least 1.5 to 2 times higher. Looking at Brazil specifically, 3/4 of the population are linked to the public system called SUS, and 1/4 has a private insurance program. On the other hand, the expenditures are delivered mostly to the private than to the public. so in the opposite direction. Regarding high-cost medication, we know that almost 90% of the new drugs launched were consumed in the US, Europe, or Japan. In looking at Brazil, for many years, no novel agent has been approved for the public system. The last agents were rituximab and trastuzumab for the public. And for prostate cancer, in the advanced disease space, only docetaxel and ADT are available. So look at the potential of Brazil and Latin America. I would say that the potential is huge. Brazil has a population of more than 200 million people. It represents the 7th most important oncology market worldwide and the 9th most powerful economy worldwide. And looking at research specifically, we belong to the LACOG, the Latin American Cooperative Group. The LACOG has many institutions affiliated with, and according to the LACOG statistics, there are more than 32,000 new cases per month. And look at prostate cancer specifically, more than 2,600 new cases per month. So talking about solutions and projects that not only us, but people in the audience, there are a lot of Brazilians here are looking for and working together. So the first project is transforming public hostels that provide only medical assistance in less favorable socioeconomic areas with a high-density population into research clinical units. There is a win-win situation, particularly for the patients. The first, because the patients has the opportunity to be enrolled in top-notch clinical trials that has been ongoing in the best cancer centers in the world. Second, because the Brazilian law tells that the pharma has to pay for everything, so there is a save money for the public system. Third, the patient enter on the trial overcome the issue about limitation of drug access. Fourth, we generated jobs and improve the country intellectuality in research. Fifth, we can help in improving the biodiversity, including Brazilian patients' international clinical trials. And last but not least, we develop a health chain with AI to perform a big database looking at patient real-world information. So this is the major project of the Instituto Vencer o Câncer, called Beat the Cancer Institute, and I have to declare that I'm a co-founder. So we have already created 6 research unit centers in the north and northeastern part of the country, the poorest areas of the country. One is the state of Amazonas, one in the state of Pará, one of the state of Maranhão, one of the state of Paraíba, one in the state of Bahia, and one of the state of Mato Grosso. So these are some pictures of the centers that have been created. And at the end of this year, the goal is to have 20 research units along the country inside the public hospitals that only, again, provide medical assistance. And by the end of 2026, we'll have 50 new units. The project, we can have the power to scale up because it's not expensive. We have just to certify the center, hire the adequate people, and the centers are able, again, to participate, as they are doing right now, of international clinical trials. Another solution, instead of creating centers, is to make the centers that already happen to participate in clinical trials. And one of those that is particularly very interesting in our region is to look for innovative treatments for frequent tumors in developed countries. There are rare tumors in developed countries. And this is one of the examples, the Hercules trial, that has been led by the LACOG team, and we have many investigators here in the APCCC. So this trial that has the support of MSD is a phase 2 single-arm trial in penile cancer patients, metastatic or recurrent disease, evaluating chemotherapy plus pembrolizumab, followed by pembrolizumab for those who had control of disease. So we're happy to say that this trial for epidemic disease in the country was accepted for oral presentation at the following ASCO. Under the umbrella of the HPV-related tumors, we had another trial to be started in the second semester in the same patient population for those who receive platinum-based chemotherapy, randomized between maintenance cemiplimab versus best supportive care in a phase 2 randomized fashion. And the same for vulvar cancer, which again is epidemic in the country and is very rare in developed countries. So looking at a different angle of the clinical research. So the other thing that our group is working on is to promote practice-changing trials of frequent tumors in developed or developing countries, but trials that only are possible to be done because of our unique characteristic of the public system, the SUS. So this is a trial that we are going to start next semester called Redempted Trial. So this trial is going in a randomized and no-inferiority design, include muscle-invasive bladder cancer, eligible to cisplatin, where all patients receive neoadjuvant chemotherapy, and then they will be randomized to answer such important question that has never been answered in a level 1 evidence. If chemoradiation is no inferior to radical cystectomy. And why this trial is possible to be done in such a common disease in Brazil? Because in the public system, most of the patients will undergo to radical cystectomy because there is a lack of radiation facilities. But in the trial, there will be a 50% chance of having surgery and a 50% chance of having the bladder preserved, and you'll see the results on a longer follow-up. So now changing to promote access to oral oncology medications. This is another project of the Instituto Vencer o Câncer. We written a law project to expedite the access to oral oncology medications. We built up a national campaign with actors, singers, TV sportsmen. And we're happy to say that this project was approved by unanimous decision in the Senate. And the result is to accelerating 6 times faster the access to oral oncology medications for more than 50,000 patients a year. And last but not least, improving education by consensus for developing country. We have been inspired by Silk and Aurelius from the APCCC. So we had this consensus for more than 200 physicians from developing countries, 17, and the results were published in 7 papers in the Journal of Global Oncology. So as a conclusion, clinical research has the potential to overcome the limitation access to optimal cancer therapies. Healthcare policies that are able to harmonize the public budget in order to finance the most cost-effective treatments to be delivered to all patients are a reality and need to be done more often. Physician and patient education are a key to optimize patient care according to each region's specific characteristics. So the bad news is that you have many limitations, many obstacles. The good news, there is a huge room for improvement. And the other good news is that many of the solutions depends exclusively on us. So thank you very much for your attention.
So, and last but not least of the formal talks, we've got Dingwei Ye from China, who is going to give us the perspective from the Chinese healthcare system. And as we saw at the beginning, there's going to be a huge rise in cases in China, we project. So this is extremely important.
Thank you, dear Chairman, distinguished colleagues, good afternoon. So I'm from Fernando University, Shanghai Cancer Center. Actually, I'm a urologist. So I'm going to talk how to deal with the projected rise of prostate cancer cases in China. You can see here in the past couple of years, the incidence of prostate cancer increased dramatically. So year 2022 already ranked 6th in the incidence of rate of male cancers. So last year we performed 1,700 cases of radical prostatectomy. But it's not balanced. Actually, in the urban, it's higher than rural area. Also in the Shanghai, actually, the prostate cancer is already the top 3. So 5-year survival rate is lower than that of other countries, even the East Asia region countries like Japan and Korea. Year 2022 ranks 7th in the mortality of male cancer. So the main reason is the early diagnosis rate is simply low. Nearly 60% of the initially diagnosed prostate cancer were locally advanced and metastatic disease. So this is necessary to explore how to deal with this situation. How to deal with the rise of prostate cancer in China? Actually, in year 2019, the State Council launched the Health China initiative. The purpose is to improve the national health level. Also, last year, the Chinese government launched the action for the cancer prevention and control. This can be seen that how to deal with the increased of the prostate cancer, the cancer patient is already become the national strategy. So enhancing public awareness is a very important measure. Actually, the Chinese government, also the medical facility, try to do the prevention science popularization and arouse the people's attention. So regarding the screening policy, actually there are national screening policies for breast cancer, GI, even liver, and lung cancer. Unfortunately, there was no for prostate cancer. But for the developing areas, economic developed area like Chinese East Coast areas, local government and medical facilities just establish their own screening strategy. Also, the Prostate Cancer Committee of Chinese Anti-Cancer Association formulated the consensus. Also, they just increased a lot of weapons, new technologies in the consensus, try to improve the accuracy of the diagnosis. So in order to improve the outcome of the treatment, the Chinese government constantly add a lot of investment for introduction of medical equipment and new drugs, even the integration of new resources. I'm a urologist, for instance, for the Da Vinci robotic surgery system. In the past 5 years, over 300 machines setting up in China. But there is a significant region gap. In the Chinese East Coast areas, the economy is relatively speaking developed, more concentrated of the equipment. Also, a lot of domestic brand of robotic machines emerging. The clinical trial is ongoing, like Renovo, Tomai, and Jingfeng. For instance, in our center, the domestic robotic surgery system, Haishan #1, we just finished the clinical trial. We found that there is no significant differences in the surgery times, bleeding, and even the complications. So accelerate the drug approval, also very important. For instance, enzalutamide just took 7 years for commercial launch in China after the FDA approved. For the olaparib, only took 1 year after. Actually, most of the drugs already bring into the medical insurance coverage. So in order to increase the speed of the approval of the new drugs in China, actually Chinese experts also developed their own drugs independently. And for instance, rivarotamide is a new NJHI developed in China. 2 years ago, got approved in China. Soon bring into the medical insurance, which simply benefit for the vast numbers of Chinese patients. So in order to improve the outcomes of the treatment, prostate cancer care, we try to promote the MDT approach in China. Also, the model of the MDT approach involved from the classical MDT face-to-face discussion in hospital, with the development of the National GU Oncology A-Links, and also with the improvement of the Internet Plus, the MDT network nationwide. In recent years, with the 5G generation, 5G internet improvement, also a lot of international experts just join us for the online discussion, actually bring convenience and breakthrough. Also, the geo-oncology community issued the consensus. So the domestic standard for the prostate cancer care also involved, firstly drawing into the international guidelines to develop their own guidelines. Also, Asia-Pacific colleagues work together for the consensus, specifically for the Eastern areas patients. Also, a lot of studies in China are also incorporated in the international guidelines and again the recognition. So we try to promote the internationalization. We hosted the Asia-Pacific Prostate Cancer Society annual meeting. Also last year, we hosted the preceptorship for the next generation imaging. Most of the speakers just from the top centers of Asia-Pacific focus on the precision medicine of the prostate cancer. Summary, the incidence of prostate cancer is rising rapidly in China with a significant imbalance between urban and rural, southeastern coastal, and the central western regions. China does not have the national level PSA screening policy, but is exploring screening strategy in economically developed regions. Chinese government has made great efforts to enhance public health awareness, accelerate approval of new drugs, introduction of equipment, and the support of original research. Chinese experts are actively promoting the MDT model and the internationalization of the cancer care in China. Thank you for your attention.
So we're able to take questions now. Everybody's stuck perfectly to time, so we have time for questions. We have one online question at the moment, which is when we talk about prostate cancer incidence, mortality, and management in Pakistan, it's asked for what numbers and percentages. So I think that's a question we can't answer directly because we didn't look specifically at countries, but we did look at regions, and it's very clear that Pakistan will see the same sorts of trends as we've outlined. So the same issues apply. So if there are no questions from the floor, one of the things that, just coming back to the diagnostic pathway, and specifically, you gave a very clear outline of diagnostic pathways in Nigeria, and it's obviously a huge country with a huge population. How variable is availability and access? You, at the one end you're saying MRI, and at the other end digital, digitally guided biopsy, for example.
No, MRI is still very limited in number. And so even where they have just installed the machines, they need to train people how to utilize that. But ultrasound-guided biopsies is commonly done. But also there are several centers that don't even have that. And because the patients come late, so if you put your hand into the anus, you can actually guide and see a lesion and get it. So we know that the diagnostic, there are challenges in terms of yield, but because the patients come very late, they are also able to detect up to 60%.
I'll just say something too. I think just to add to his comment, at least, when you think about the diagnosis, like MRI, in places like Lagos State, right? It's about 20 million people. It used to be the economic capital of Nigeria. So we have quite a number of MRI machines in Lagos State. But in other regions of Nigeria, we still have that disparity. Like in Port Harcourt, he's from the south-south, right? They have the machine there because that's a coal city. But when you go to regions, there's still regions that don't have this availability of these services. So it's a little bit skewed, just like I mentioned, that you have the rich that are able to afford this treatment, and you have the poor that, it's financially toxic for them to access services because it's out-of-pocket payment. Thank you.
So, questions?
Hi. But just wondering if you could help us prioritize a little bit. It seems like in countries like Nigeria, I mean, we need help with everything, from screening to initial treatments to imaging to management of advanced metastatic disease. If you were going to prioritize one or two areas to start, what would be sort of the best, way to bring something to change, the outcomes in this setting? And I'm just curious, what do you think would be the best value to start?
I think the best value would be to reduce the diagnostic interval. First of all, if we increase the awareness and then early detection, it will help, because now we have started having a few patients coming early. We offer either radical radiotherapy or radical prostatectomy. For now, we do open and laparoscopic. We don't have robot yet. So, but if we, looking at the outcome, so if we can improve the diagnosis early, it will help us. So if we can get a few more people to support, increase the awareness screening, it will help.
So just so I understand, if people were aware, would access to screening, to say PSA screening, be widely available, or is that something still that you don't have the health system structure to do?
Yes, first of all, even the standardization of the PSA, because of loss of control, only in few well-established hospitals that you can actually utilize the PSA. There's a lot of variations, and many laboratories are not standardized. So you cannot even utilize the PSA results. So if we have well-established laboratories where the PSAs can be done, it will help.
So starting with just sort of a mechanism to broadly, create access to PSA, some kind of mobile, labs or things like this. Yes. I'm just trying to understand where we can, because it seems to me, I agree with you, that's where we can make the biggest impact, is just diagnosing people earlier.
Yes, and then if we can support, even if it's ultrasound-guided biopsies, to be widely available, it can help also in terms of diagnosis.
That's great, thank you.
So actually, Fernando and Maluf just bring in a minute, but we have 4 additional panel members. We were planning to have a separate panel discussion at the end, but I think it might be worthwhile having the additional members introduce themselves who haven't spoken, so we can draw you into the Q&A as well. So I can't see who's sitting in which order, but maybe if we start nearest me and move away.
So to answer Dan George's question, when you look in Brazil, the public versus private, the chance of someone in the public system get diagnosis early is 3 times less than in the public. Because in Brazil, PSA is opportunistic, it's not obligatory. So the patients are not informed. But when you look at the same patient, same stage, public versus private, you have a database, you haven't published yet, but the mortality for localized disease, public versus private, is twice as more in the public. So we couldn't dig out the treatments, but in our opinion, many of the patients with localized disease, the lucky patients with localized disease in the public system, probably have been treated palliatively, not curative. So I think one of the works is screening to the high-risk population, because the country cannot afford screening for everybody, because the problem is not the PSA, it's what to do with so many people getting the diagnosis of prostate cancer. I mean, how they are going to be treated. If no screening has been done, the delays in surgery and lack of radiation therapy is a big issue at this point. And secondly, how to optimize treatment, such as hypofractionation, developing centers, high-volume centers to do the radical prostatectomy, change the agonist-antagonist for orchiectomy. So ways to optimize treatment. So my major concern is the curative part of the disease. Of course, we're thinking about the patients with metastatic disease, but you don't have available treatment for the localized patients. And that's, for me, is the biggest issue, and that's where probably we would invest more money to cure patients, because one is curable, and second, it's much cheaper than patients who evolve to metastatic disease.
And just to comment on the PSA testing thing, so one of the things we tested in this ManVan project I've been running in London was a point-of-care machine. In the end, we decided it wasn't particularly useful in the context we were doing, because we can turn around venous bloods reliably within 24 hours anyway. But we did test the machine, and it was very accurate, and it's the size of a desktop printer, and it functions on just straight mains electricity. So it's quite a practical solution for mobile testing that is very easy to roll out. So next question for the floor.
Yes. Well, so first of all, I want to congratulate the organizers for this panel. It's not trivial to see in such a high-level conference a panel like this. So thank you for the opportunity to see that, and for the panelists, it was amazing. And more, I know Fernando's initiatives in Brazil and his initiative in providing and organizing the developing country consensus. It was a very important initiative. And going in that line, what we feel normally in developing countries, I'm also from Brazil, is that it's not easy for us to publish our own data. So we tend to create our own papers, but after a short while, these papers tend to follow and try to improve their impact factors and act like developed world papers. So, for instance, all this data that we have just seen, impressive data from Africa, from Brazil, from China, from India, it's hard to see this data published. So my question to the panelists, to the North American panelists and to the South Hemisphere panelists, is how do you see opportunities to demonstrate this data, not only good data, but also real-world bad data that we see, and maybe we can work on that data to foresee opportunities to improve healthcare for underdeveloped or developing countries.
So, Vedang, can we maybe ask you to comment on that?
How to publish our data? That's the question, isn't it? There's a lot of stuff happening. How do we publish it? I think, to be fair, I mean, 10 years back, I used to think that we really cannot publish. They don't accept. They reject. It comes from India. They reject. I had that kind of a feeling internally. But over the time, I realized that if you present it well, it is about packaging it. And we have to learn to do that. We don't package any of our thousands and thousands of patients that we see. So we must learn to do that. I think that's what I tell my residents also. How you package it, how you sell it to the world is important. And I think our focus has to be there. Because the data is all there. How you sell it to the world is is what I have learned over time. That would be my comment.
Yeah. And I would say that you've been particularly successful at doing it as well. So which is why I asked you. Yeah.
Hi. So thanks for these very, very interesting presentations today. I have a question, especially for Dr. Maluf and Dr. Murthy from India and Brazil, because what I heard from you is that there is a big opportunity in your country to participate into clinical researches, both sides, I would say, because you have a very densely populated countries, and on the other side, the patients may also benefit. My point is, all the limitations to the health systems that you presented us may also be applicable outside of the prostate cancer management. So, for instance, when it's about safety reporting into clinical trials, or, for instance, management of comorbidities, don't you think that these may somehow impact the data of the clinical research? And how can the scientific community interpret the intrinsic limitations that you now explained as exist in your countries in clinical trial, especially with long-term outcomes like overall survival?
Yeah, I think it's a good question. You know, many of the trials that have been run in Brazil have been audited by FDA and by other agencies. So I think my feeling, yes, physician education has to be continuous. There is room for improvement. But like Brazil and some places in Latin America, they are quite mature to participate of the trials and even leading it. So there are some trials that Brazil is leading. It didn't happen 10, 15 years ago. If I mentioned that 10, 15 years ago, you know, people will call me crazy. But this is a reality. And I think one of the reasons for that is because there are many more trials than before, but the population did not increase that much. So now, having Latin America as a continent with so many people and so many patients, now becomes an opportunity for patients, but also for the pharmas to run the trials in the country. Again, because I don't think that the coexisting, traditional countries are going to run the trial as quick as they are in the past, because the number of the drugs and the number of the strategies have increased exponentially. So I think it's a win-win opportunity, and I think, in my guess, the researchers, and you have many researchers from Brazil and Latin America, they are quite mature in their centers. And these centers that I mentioned, that we created, these new research units, yes, it's a process. Initially, they're not going to do complicated phase 3 trials, but there are some easy and not that easy trials. So we are now filtering and connecting the feasibilities to the centers.
Thank you.
So last question from this part of the thing, Paul Nguyen.
Yeah, thanks, Nick. And this is such a great panel, and I love to see all the convergence from the panelists here. And I do have a question for Stacy Loeb, but just before I do, I know, Nick, you had wanted the panelists on the left to introduce themselves, so I'll pause for a moment and let them introduce themselves before I ask my question.
I did, yes, thank you for I just wanted to let the discussion run. So we have additional panelists down the far end who we picked for various reasons. So I'll ask you to introduce yourselves, just to say about your background, and then we'll let you ask your question. And we have online a panelist as well who is unable to attend in person. But yeah.
Thank you so much. I'm really glad to be here. I'm Murthy. I'm from Tunisia. For who don't know where is Tunisia, Tunisia is a little country in North Africa. So I will talk about Tunisia and what we have in Tunisia. In Tunisia, we have two sectors, private sector and public sector. And really, we don't have problem with diagnosis in prostate cancer since we have MRI, since we have biopsy, guided biopsy, since we have healthcare professional who do a good job, but what really we have problem with high-cost medication, and we have late approval for this medication. This is mainly the problem in Tunisia.
Yeah. Thank you. I think James is next. Yeah.
Hi, I'm James Endau, Professor of Urological Surgery in Aberdeen. As you can probably tell, I wasn't born in Aberdeen. I was born in the Gambia, West Africa, and I've been there 38 years now. And I had the great privilege of working with Nick and others, looking at the early detection, chairing that subgroup. I've spent a number of years as chair of the EAU guidelines, and the past 2 years, Adjunct Secretary General in the EAU, responsible for the education portfolio. Thank you.
Well, Nick, I will take 2 minutes to explain why I'm here. I'm Franco Cavalli. I am not a prostate cancer specialist, and I'm not here because I have built up the Cancer Institute, of which now Silke is the director, but because of the World Oncology Forum. So I am enlarging a little bit the topic, but it is very similar in many tumors. So the World Oncology Forum I created for the European School of Oncology to assess regularly the situation in the global fight against cancer. In 2012, we met in Lugano to answer the question, are we winning the war against cancer? 100 worldwide experts were here, and the answer was scientifically yes, globally no. We put together an appeal with 10 measures which should be implemented. We met many times, and last September, where we tried to evaluate whether in the last 12 years the worldwide situation has become better, worse, or the same. I mean, we are very concerned because just looking at the low and middle income countries, it is calculated that between 2020 and 2040, the mortality for cancer will increase by 100%. And looking just a few data, more than 1/3 of African countries do not have one single radiotherapy machine. 75% of breast cancer patients who need that do not get trastuzumab, and so on and so on. So we came to the conclusion that there are a few very important things which we should do together. The most important one is that we have to convince the international political organizations to deal with the cancer problem. They refuse to do that till now because this has to do with improving the healthcare situation. So G20 and G7, they refused up to now to do that, but we have to put a lot of pressure in order to convince them. Because we need some resources to start tackling the most important issues. We have calculated together with the World Bank somewhere between 10, 15 billion a year, which is not a lot if you consider that last year 2 trillion were spent for weapons. And looking at the most, WHO, you will hear, has launched now 3 big projects in cervical cancer, breast cancer, and childhood cancer. They are very important, but there are bigger issues. The most important point is to invest a lot in prevention and early diagnosis, because even in the rich countries where we have somehow a decrease in the cancer mortality, this is more due to prevention and early diagnosis than to treatment. And we know how prevention and early diagnosis could be structured in the low and middle income countries, but we need to invest in that. And we have to invest in treatable cancer, for instance, through having many more radiotherapeutic machines, but to have also drugs. I mean, yes. India has shown one of the way with this global procurement, but there is a huge problem. We have put together the 10 most important issues, and one was to have the possibility to have a new model in generating new drugs, which would generate drugs which are useful but also accessible for the vast majority of the world population. And this has not improved, has gotten worse in the last 12 years. But there are possibilities. One is the Indian possibility. The other one is that nations should use compulsory licensing to oblige. They can do that according to the international law, and they can get then cheap generics, good generics, even if the drug is still under patent.
So I'm just going to stop you.
I am just stopping.
Yeah.
Just stopping. But I think that it is our responsibility as a researcher and as physician to build up this pressure, because cancer within 20 years will be the most important cause of death worldwide in all countries.
Thank you. And absolutely, you've covered loads of points all in one go there. So just to do two more quick introductions. So we have one person online, but just to finish the row here first.
Good evening, good afternoon, everyone. It's Raffaella Casulino, medical oncologist and technical officer with the cancer team at WHO headquarters in Geneva. And there is also my colleague, technical lead for the cancer team online, Andre.
So I can see Andre in front of me, but I don't see him behind me.
I think that he can speak. Can we hear?
Yes, can you hear me?
Yeah, perfect.
Wonderful. Well, I'm very sorry to not be there in person for such an important discussion. I'm based in Jerusalem, and given the difficult situation here, I've been unable to travel. But I would just like to make a brief remark of appreciation to you, Nick, and to the organizers for putting prostate cancer so highly on the agenda, because as you heard from Professor Cavalli, the initiatives we have started at the grassroots. And the session today, the meeting you're having, is a reflection of the grassroots activation that's happening in prostate cancer. I hope we can comment on where WHO can support, but first and foremost, and most critically, congratulations.
Thank you. So, Paul, thank you for being so patient. I have one more question from the floor as well, but we'll take your question first, and then we'll go to the panel discussion, which we've kind of half had now.
Super, thank you. And what a great panel. It's really an honor to have everyone here. So my question for Stacy is, Stacy, you pointed out the value of social media, both in the developed countries and in the lower and middle income countries, but also pointed out this great danger of misinformation. So what are some of the strategies that can be used to counter this health misinformation that's out there in developing and low and middle income countries?
That's a great question. And first and foremost, they have these expressions like dilution is the solution to pollution. So even what we're doing here at this conference with millions of impressions, having scientific experts participate in dissemination of evidence-based information is absolutely critical. So as healthcare providers, getting involved in public media, and also even giving information prescriptions to our patients. As you can see, if somebody just goes online and searches, the top things that come up are very likely to contain misinformation. So I think we actually need to be proactive about telling people good sources of representative, understandable information and contributing to the content wherever we can. But, I think we can't do this alone, and we do need buy-in from healthcare professional societies, governmental organizations, international organizations, in putting out high-quality information.
And actually, a related question from the floor is, we've traditionally gone to people like pharma companies to help us fund our research. I mean, should we be going to tech companies to help us fund communication strategy?
I think it's absolutely critical, just like we have, these partnerships for the development of new treatment strategies. And this whole topic just needs a lot more attention. In medical training, there's not enough attention to public-facing communications. There's a brief period in medical training about patient-physician communication, like in a one-on-one encounter, but not so much training on the media and how to present what we do to lay audiences. So I think all of that needs much more attention.
So we have another question. We have two questions. I think Niraj was first, and so for the whole panel, and we have a lot of experts here in all sorts of different things. So Niraj first.
Yeah, what a fantastic panel. Such a great learning experience for me. So Vedang, Stacy, Dr. Ye, everybody, great points. So coming to the telemedicine, how do you manage side effects? So prescribing abiraterone, low dose, all sounds great. But I think managing side effects through telemedicine can be very challenging. Inequalities exist everywhere. It exists where I practice. So what can I learn from you from the perspective of managing the side effects such as blood pressure, hypertension, hypokalemia of abiraterone? And this can be extrapolated to any treatment. Vedang?
Well, I can talk about radiotherapy. Hypertension is not one of the problems that we create. It's fairly simple, I think, for prostate radiotherapy if we are talking, and we have developed this whole trial. This is especially for the trial patients. I mean, we were talking about how to make the data more robust coming from India and Brazil. So there is this trial WhatsApp whole system that we have created, and patients report in their toxicity, their CTCA. We give them a little form, photo. They tick that, take a picture and send it back. So that is one way to do it. We also collect quality of life on that. So that is a record for us. So that's how we do it in the trials. That is telemedicine, isn't it? That's
yeah. And of course, you talked about national cancer grid. I'm sure the primary care doctors who can learn from the oncologist in the big hospitals, right?
Yes, I think that's a huge opportunity. That basically the most important thing that NCG will do is get everybody on the same platform, and so that information and resources can be shared.
Thank you very much.
So I have a question for Andre online. So we're very keen to facilitate more research in low and middle income countries in particular, and we're very keen to hear how we can work with organisations like the WHO, which is an organisation I've never worked with before, in order to facilitate this, because there's clear expertise, willingness, and we've got a big audience here in the room as well, and a lot of the audience, like Neeraj who just spoke, has links back into India. So whilst working in America, there's a huge amount of goodwill we can harness. How do you think we can do this?
Thanks, Nick. The timing for this question is very appropriate. WHO, just to briefly reference, is an organization that has an agenda driven by governments. And for the overall health agenda, last year they put on a resolution on clinical trials and innovation. So there are significant work being done, and I'll pass the floor to Dr. Castellino shortly to have her comment on our specific work in cancer. But we are now fostering regional networks in clinical trials, and cancer is one of the primary interests for this work stream because of its relevance to impact its agenda. And as we say often, for cancer, innovation is best achieved through collaboration. We heard already what clinical trials have been able to do in terms of advancing the science of cancer control, but it's also important to acknowledge the role that clinical trials can offer to build capacity. And that means, again, to foster partnerships between cancer centers in different countries and doing so in a sub-regional network. So the potential to invest in clinical trials is perhaps the strongest instrument that many of the audience would be able to walk away from focused time and effort. In order to define the work stream, we spent some time understanding the landscape of cancer clinical trials. And I would like to acknowledge Dr. Castellino for her work to better understand what is the current state of clinical trials in cancer. So perhaps, Rafaela, given your efforts, if you don't mind sharing with the group just a bit of what we've discovered and some of your thoughts on how we can foster the type of collaboration moving forward.
Thank you, Andrea, for the introduction. And as Dr. Hilbawi highlighted, member states in 2022 passed a resolution on clinical trials, not just for cancer, but broader clinical trials, recognizing the importance of research and to strengthen the clinical trials network, but also addressing the ethical issues related to clinical research. Within this context, we are trying to address the specificities of cancer clinical trials. And to do that, we started several activities. First of all, we started analyzing the clinical trials landscape, mapping what are the clinical trials around the world through a resource that is available and curated at WHO. And this resource is the International Clinical Trials Registry Platform, which includes 24 24 different international cancer databases. We extracted more than 100,000 clinical trials, and we looked at characteristics basically focusing on equity and inclusion, first of all. So where are the clinical trials conducted? What are the specificities on the different cancer types that are more included in clinical research. But I think that for this preliminary analysis, one of the key messages that we are getting is, of course, research is mainly focusing, has been mainly focusing in high-income countries, while low and middle-income countries have only a small proportion of clinical trials. And these data generate a question about the relevance of the research questions that we ask. Are the clinical research questions that we ask in high-income countries relevant for low-income countries? The answer is not automatically yes, so we need to listen more to the local priorities. We don't have to adopt the colonialistic approach and go into low-income countries and say, we have these international clinical trials, we just want to include participation there. But we need to ask, what are the relevant priorities in your countries? What is the burden of, what is most, the cancer type that is impacting the most? But also, what are the kind of questions from implementation research? We all listen to the interesting inputs from the colleagues from India about implementation research. We need to focus more in implementation research. We need to better understand, not just looking at new drugs, but to better understand how can we optimize already available and approved treatments, not just systemic treatments, but also radiotherapy. How can we improve the escalation, hypofractionated radiotherapy without compromising efficiency? So these are the key questions that we need to prioritize if we really want to improve clinical research at a global level. Back to you, Andre.
Thanks, Fernando. Please go ahead, Nick.
Okay, so thanks for that response. I just wanted to kind of layer on that question. One of our panel questions, which says, how do we improve research and evidence practice? We've said so much about underrepresentation of men of African descent in clinical trials globally. So I want to direct this question to James. Could you comment on how do we increase the representation of men of African descent in clinical trials, especially pharma-driven trials? Because one of the challenges we have in Africa is that most pharmaceutical companies, they are largely set up for sales. So they don't focus on research. And I think, if we see that whenever there's an interest from the high-income country, it's easier to get them, to put these men on the trials. So how do we increase this underrepresentation? I want to hear from you.
Well, that's obviously not easy. I think the first practical option is to do non-commercial trials. That may be one, which clearly involves a stronger political will of governments to invest in that area. But I think the challenge we have goes beyond that. I actually think that the quality of data from low and middle income countries is generally poor. The quality of data across the care pathway, right, across all patients that are affected is poor. The registries we have is poor. And I think the smart investment is actually to just do a very boring bit of research and start collecting data across the care pathway of everyone who's affected with prostate cancer, so that we know about the epidemiology, about the presentation, about the mortality, so that we have a baseline. At the moment, it's all a big mess, unfortunately.
Yeah. Still, I think most countries are still at that preliminary stage of advocacy, political advocacy, to even let their government know that we need data. But on the flip side of actually I mean, I always feel that when we build capacity in this area, it could serve as reverse innovation. For example, if there's a site in Nigeria, you know that all the patients you recruit from that site are going to be men of African descent, right? And we can see there's a lot of immigration across countries. We could use it as a hub for studying men of African descent. And one of the lessons that I've learned, we've learned as oncologists in Africa, is that whenever we have international collaborations, we build capacity. Because, it's easy for you to say, do this, do the research, do that. But if you really don't have someone guiding you, and so most of the studies that we've collaborated in, now we have the first breast cancer clinical trial ongoing in collaboration with University of Chicago. We are on the Ironman registry. And I tell you that there has been capacity development from there. So the theory I've learned is different from the practical. So as we bring in studies like this, I think it's also a strategy to build capacity, right? And sometimes you have databases, registries, tools that are like RedCap. It's already available, it's widely used. But when they bring it into Africa, we learn. Right, and there's capacity building around that, and that's why I'm actually passionate about bringing these collaborations in. Yes.
Just one quick comment.
Okay.
I just show that we are able to create research units. So if you have the patients, if you have the medical doctors that are willing to do, if you have the basic infrastructure, and a third party to hire the adequate people for this mission, plus implementing the process, it can be done. We have been done already. And these 6 centers, the first new 6 centers, they are running trials in hospitals that only provide medical assistance. So we are scaling up, because it's possible. So if it's possible in Brazil, it's possible in Peru, in Mexico, in Africa. I don't think there is any difference between all of these places.
So Jason, you've been very patiently stood there, and Neha behind you as well.
Absolutely. Fantastic panel. Maybe Neha and I should shout our questions together. I bet you there's some overlap. But, radiotherapy is critical to a comprehensive cancer control plan, and it's cost effective. And we know that access to quality radiation is limited in LMICs, especially perhaps sub-Saharan Africa. And yet it's a responsibility and investment that we need to prioritize, right? It's a complex issue. It's not just getting machines, it's quality assurance, it's retention and development of human capital, and that's a major issue. That's a rising issue in the US as well. So what should we be doing as a global community to, radiation is involved in more than 50% of patient care. It's used in cure, control, and palliation, right? It's a major, major thing. What is being done and what should we be doing? Easy question.
Okay.
So James, I think your hand was up first.
Yeah, very happy to take on. I think if you look at least sub-Saharan Africa or the African continent as an exemplar, when you look at the Pan-African Urological Association, they're now really motivated to do something about this in terms of a strategy across the continent. Let's remember, Africa, we talk about it as one country. It's 54 countries, right? It's like you're talking about Albania versus France. Very different in all these countries. So they all have different economic powers, different political systems, different GDPs, all sorts. But I think what they've come up with is pretty smart, that they would look at building 5 hubs, right? North Africa, East, West, South, and Central Africa, where they have a hub and a hub and spoke, where you have a hub where experts are, not only in urology, but in oncology, radiation oncology, in research, in epidemiology, and they train people. I think building capacity, this cannot be a short game. I think for LMICs, we have to accept that there are no quick fixes. We have to plan 10, 15 years ahead. We're going to accept that people are going to die between now and then, but we must do the right things from now, i.e. build capacity, local, and collect data to show that this is where we are today. And as we improve, these are the improvements, these are the lessons learned. we cannot shortcut it. There are no shortcuts. And I think we cannot just look at our specialties like surgery and go, let's focus on surgery. No, we should have a multidisciplinary approach from the beginning. Build capacity in surgery, because if we're going to screen, it means we're going to do a shift from advanced disease to more localized disease. And we need to be able to have capacity around surgery, radiation treatment, all sorts. And we need to do that together, not as a specialty. The surgeons and the oncologists doing different things.
So Neha, before we come to Franco and Muna, I'd be very interested in your thoughts on this as well, because you're working in North Africa, because we kind of, obviously different issues potentially. So Frank.
Yeah, I think that this is a problem which could be tackled because, I mean, we have the AIE in Vienna, which is already the international organization which can organize everything in that sense. And they just would need to have enough resources, for instance, to buy equipment for the half of the countries in Africa which do not have almost a single radiotherapeutic machine. And that can be coupled with telemedicine, in the sense that teleplanning, for instance, is absolutely possible today. So a lot of the problem of the human resources concerning radiotherapy in the poor countries can today be at least tackled using artificial intelligence and telemedicine. So we need the equipment, and that's not so expensive and could be solved if the international community would give to the Vienna agency enough resources, and then telemedicine could help to manage that.
And just to add to the telemedicine component, like in Nigeria, and that's why I talked about international collaborations, the clinical trial we have in breast cancer, the plans are not approved until we have this MDT with specialists at Weill Cornell, who is on the team. Then we also have private centers that have MDTs across board, right? So it's telemedicine, you're sitting in your office, we have a question, and then we share, we do the remote sharing, and you're able to see whatever we plan there before you go ahead, know the clinical history of the patient, and move on to planning. So there is that component in, we've started that in Nigeria. But I feel that, like he said, like James said, that you have to plan ahead. It's a long-term thing. During my presentation, I talked about the National Cancer Control Plan being established in 2006, right? And fast forward all the way to 2024, it's been like a work in progress. So it's for us to then plan ahead, long-term planning, and we just keep moving the science forward. Yeah.
Fantastic. So Muna, can I maybe ask you to comment as well on these aspects in terms of telemedicine and distributing decision-making and care? And so Muna, yeah?
It's a little bit different in Tunisia. I've heard from my colleague. In Tunisia, we don't use telemedicine. For research, we use it to be in several clinical trials. Especially, I was a co-investigator in Prostate, but it was in 2010, 2009. But now I really try to bring some clinical trial in Tunisia with Karim Fizazi, with Jechuk, but it's very difficult, especially when it's academic trial, because we don't have the standard of care. So it's difficult to do 3-phase trial, and it was without success, but we never desperate. We try again, we will try again to have many clinical trials. And what I say, and for radiotherapy, we don't really have problem with radiotherapy in Tunisia. And we deal with many African patients, Libyan patients, Sub-Saharan patients, and Tunisian patients, especially in the private sector. In the public sector, it's a little bit crowded, but it's okay. We can have access to radiotherapy, no problem. as I said, the really problem is the access to this every high-cost medication in Tunisia, such as antiperp, low PSMA, and that's it.
That's it. So we have about 1 minute left. So Neha, really quick question. I'm afraid we don't have any time.
So I get the distinction of keeping us all here longer on a Friday night. Sorry. I just want to echo the applause to the organizers and to each of our panelists just for not just sharing your insights today, but the incredibly important work you're all doing. And thank you, Jason, also for the radiotherapy question. So I can jump to my second question, which is, so each of you addressed in some way, of all the various stages within the cancer care continuum, that entry point of patient awareness, patient education. But before they become patients, they are community members, right? They're our neighbors, they're family members. And I think if there's one thing social media has shown us, yes, it is the great unifier, but it also is great at creating silos and echo chambers. And I wonder how, again, with Dr. Loeb's work and each of you in your respective regions, many of which are countries with multiple different cultures within those countries, right, and regional differences. Some of the community-based research we've done at our institution has revealed a lot of community myths and misperceptions among, for example, Black and Latino men and women that we've, done mixed methods research with in Philadelphia. And by learning what those beliefs were, we were actually really quite surprised. Some things we expected, some things we really did not, and are able to then have our messaging and our education start by focusing on those areas before they ever become patients. But in fact, that penetrance into the community is so important, right? So I'm wondering how each of you might see, and maybe this is not a question to be answered today, but really just for discussion as we continue this conversation, how each of you in your countries, in your regions, within communities are going to address not just the basic prostate cancer education, but really getting at local to each of you. We're talking global, but I mean local myths and misperceptions that are pervasive and that will prevent them from hearing the message that, Dr. Loeb and others are trying to get out there. And how do we leverage social media and these other ways to get those messages out there?
I think this is probably a thing that we need to address over aperitivos outside. Basically you're saying, think global but start local, and I think that's very true. Yeah. I think we have to wrap up. We are out of time. I'd like to thank the entire panel. I think we've had a fantastic discussion, and I think what is very clear is that there are huge potential issues coming, and I think a lot of the issues are going to be outside the APCCC world as described by Declan. And I think it's really great that we've had this session today, and I think this should be an increasingly prominent feature of conferences on advanced prostate cancer, because if we want to address the whole problem, we have to address the whole world. So thank you very much.